dying of breast cancer, and mammography is far from a perfect test. We do know that the majority of women who are dying from breast cancer at this time have not had mammography. And I will just state that worldwide, there are many countries who have no mammography access, no opportunity for organized screening. And I think ultrasound has a major role to play internationally, even if there are many barriers to its implementation in this country. About 40% of women who die from breast cancer who have been screened, about half of those have screen-detected cancers that are still of poor prognosis. They may be rapidly growing, very high-grade tumors that we're really not likely to ever be able to make a difference in some of those unless we were screening extremely often, and that's not practical. But another half of those, we could make a difference. Those are cancers that are not seen on mammography, where other tests could have an impact. These are cancers that are detected because they're come to clinical evidence in the interval between screens, and many of those happen to be in women with dense breasts. The goal of any screening test is to find cancer at that early stage, and in general, at this point, we have to look at surrogate markers for success, that is, cancers that are smaller than 1 centimeter and node negative at detection. We don't have data on mortality reduction from other technologies. We also need to consider the harms, and this is where the politics of screening come to play. We saw this with the task force guidelines that came out in 2009, where they very heavily weighted the unnecessary biopsies that were induced in healthy women and came out with recommendations against screening, routine screening of women in their 40s. I'm going to speak a little bit about the results that we saw in the ACRIN 6666 protocol looking at screening breast ultrasound in addition to mammography. I will just point out the title says high-risk women online, and that was our original title, but I will mention that over 75% of the women in the ACRIN trial were only of mild increased risk. They had heterogeneously dense breast tissue and one other risk factor. Many of them do not meet the criteria for MR screening, which is still most appropriate in women who are very high risk. In the ACRIN trial, we had 111 women diagnosed with cancer. There were 7,473 screens over a 3-year period of time. The ultrasound was physician-performed and independent of mammography. And I'll just point out the fact that actually mammography alone or ultrasound alone had equivalent performance. Each detected 52 to 53% of the cancers. If we look at the supplemental yield of ultrasound, 29% of cancers were seen only by ultrasound. The vast majority of those were indeed invasive cancers with a median size of 10 millimeter, and the vast majority were node negative. So while we don't have data showing mortality reduction, we do know from prospective multicenter tightly controlled study that we do find the types of cancers we need to find by doing screening ultrasound. And the yield is quite substantial. That's a 29% absolute increase in sensitivity. Here are just some examples. This is a 46-year-old woman who had an elevated 5-year risk and extremely dense breast tissue mammographically, nothing seen. Here was a 2 centimeter grade 1 invasive and intraductal carcinoma that was node negative. Another woman with extremely dense breast tissue, 50 years of age, elevated lifetime risk, and here she had invasive lobular cancer found in the right breast that was node negative, and another invasive lobular cancer, 8 millimeter in size, in the left breast that was node negative, both seen only on ultrasound. However, there were false positives, and I think any program that's considering offering screening ultrasound certainly needs to inform women of this risk of false positives. They need to be aware that there is at least an overall 5% increased risk in having either an additional short-term follow-up or an unnecessary biopsy. And those are the rates on incidence screening. So the first year, prevalence screen, you're going to have even higher rates of false positives. But in years 2 and 3, these are the rates that we observed. And importantly, one of the big criticisms is that among those lesions that we biopsied because of ultrasound findings, only 10% showed cancer. And so it seems like a lot of unnecessary biopsies. I will just point out that doing an ultrasound-guided biopsy is a very simple procedure that takes about 15 minutes. And I know that if we had to recommend an MRI-guided biopsy and everything that we saw that was of any concern on ultrasound, that we'd have a far higher PPV, far fewer biopsies. But it is an issue, and here was a patient who again had dense breasts and elevated lifetime risk. On mammography, you probably can't see very well, but she did have clustered calcifications that were suspicious on mammography, and that was intermediate grade DCIS, not seen on ultrasound, but the ultrasound did show this slightly indistinctly marginated mass, which was simply a ruptured cyst, and this caused an unnecessary biopsy and did not show her cancer. So at this time, we certainly are only advocating supplemental screening with ultrasound, not meant to replace mammography. Cysts are a big issue with screening ultrasound. I think in the historical literature, something like 7% of postmenopausal women were thought to have cysts. In fact, it's nearly 40% of postmenopausal women who have cysts, and even very common in women who are not on any hormone replacement therapy. And in fact, at least 14% of women in the ACRIN trial had complicated cysts with debris that could be misinterpreted as a solid mass. We did learn over time in the trial to be less aggressive with such lesions, and in the protocol we allowed that they could be dismissed as a benign finding if they were in the company of multiple simple cysts, but nonetheless they were prevalent, and many of these ended up with short-term follow-up at least, and you can see that there were 2 malignancies, a very low rate, but nonetheless this was a common source of false positives and short-term follow-up. So if we had a better way to identify complicated cysts and dismiss them, that would be helpful. Here are just some examples from my own experience of a few lesions that were very difficult to tell. This is an anechoic small mass. It looks like it could be a cyst. And if the patient had many other cysts, certainly it would be easy to dismiss this. This happened to be a patient who had a metastatic lymph node with unknown primary, and this was targeted ultrasound directed to an MR finding. This was a high-grade invasive carcinoma. Another patient which I had followed, this was a new lesion in a patient who had prior cancer, and at 6-month follow-up, at a year follow-up, it had grown. This was papillary DCIS, but again, looked like a cyst on the initial ultrasound. So elastography does have tremendous potential to help us with cysts and complicated cysts, as well as solid masses. And again, this will look at the stiffness of the mass. It could certainly help us reduce false positives, and I'll show you some of the data to support that statement. On ShearWave elastography, simple cysts do not propagate the shear wave, so they have a characteristic appearance being black inside. The surrounding tissue is also evaluated and appears soft. I will just point out that we do show blue as soft, and red as hard, and we use a maximum of 180 kilopascal for breast elastography. Here's a mass that looked like it might be a complicated cyst. It's oval. It appeared to maybe have a fluid debris level, but it was quite stiff, especially in the surrounding tissue, and very heterogeneous on ShearWave elastography. And so this makes this a suspicious finding. This was biopsied, and it was a high-grade carcinoma infiltrating ductal. A mass here that might be mistaken for a lobulated cyst, except for the fact that it did have internal vascularity, so that was of course suspicious, and it was stiff, especially in the surrounding tissue on ShearWave elastography, and again, this is a high-grade invasive ductal carcinoma. So one of the frustrations with ultrasound is that when we make a mistake, we make it big, because some of those cancers that are the most aggressive with the worst prognosis are the ones that can appear nearly anechoic with posterior enhancement and resemble cysts. And of course, cysts being so common, this is one of the pitfalls, and I think one of the reasons that people are a little shy about doing screening ultrasound. It's a fear that we're going to miss the worst type of cancer. So in the BE1 Multicenter trial, we had 16 sites in Europe and the United States. We actually have this paper in Presta Radiology looking at the first 939 lesions. We looked at the subset of masses that were oval and circumscribed with no suspicious findings, because those really are the most likely to be able to be downgraded to follow-up if they're soft. And among those 181 lesions, we had many that were classified as BI-RADS 3 with 6-month follow-up recommended, including 4 malignancies. Very few, only 2.8% of those masses, but nonetheless a problem. And there were another 37 such masses that were considered of low suspicion, recommended for biopsy, BI-RADS 4A, and no cancers. Well, what if we use ShearWave to help us with that subset of cases, which is nearly 20% of all the cases in the trial? It turned out that just even looking visually at the stiffness, all 4 of the cancers that originally had been considered BI-RADS 3 would have been upgraded to biopsy because they were all stiff. And in fact, all 34 of the benign lesions with that appearance that were considered 4A originally would have been downgraded to follow-up. So we would have both increased our sensitivity and improved our specificity. Here is a patient who had a palpable oval mass that was among those lesions that were considered 4A. It does have internal vascularity. Given her age of 27, it's not surprising this was a fibroadenoma. It does appear soft on ShearWave elastography. Another case that was one of those BI-RADS 3 lesions that looks relatively circumscribed, maybe even with a fluid debris level. And this was very stiff on ShearWave elastography, and this was would have been correctly upgraded to biopsy with grade 3, again, invasive ductal cancer. And finally, this one, which, if you look carefully, has a little tiny tail, on the end of it, on the right-hand image, but it does look very nice and circumscribed and oval on the left-hand image on B mode, and very stiff again on ShearWave elastography. And again, this is a high-grade invasive ductal cancer. This is a lot of data this time of night. I'm not trying to scare you here, but the bottom line is we looked at a lot of features of elastography, and just having the mass look heterogeneous on the ShearWave with a mixture of color patterns was very predictive of a more suspicious appearance. We could upgrade those lesions to biopsy if they were otherwise BI-RADS 3 and downgrade the homogeneous lesions that were 4A. Overall improvement in specificity from BI-RADS alone of 61% to 78% by adding homogeneity, or very similar results if we just looked at the color stiffness, which was very highly correlated with the quantitative maximum stiffness. We then also just reported today the results of a subsequent series of 623 masses that were also accrued in the same protocol. A similar rate of malignancy, relatively small lesion size of 12 millimeter, and we saw even greater improvement in specificity in this subsequent set of cases from 42.9% with the original BI-RADS to 72.7%, just looking at those near the threshold BI-RADS 3 and 4A masses with reclassification of those that were most suspicious BI-RADS 3 and least suspicious BI-RADS 4A lesions. One final point which I found amazing about this was that we looked at the quantitative stiffness relative to specific histopathology. And again, we presented this afternoon, looking at the entire data set of 1,562 breast masses. Again, lesion size of 12 millimeter, overall 32% malignancy rate, the vast majority of which were invasive. We looked at the exact stiffness and specific histopathology. Here's just one of those cases, which round mass, 2 different patients. The one on the left was soft. This was a fibroadenoma. The one on the right has a very similar appearance on B mode, but you can see on the top right image that it was stiff. This was an atypical papillary lesion on core biopsy and DCIS at excision. It was very interesting that the very soft masses were exactly what you might intuitively expect. Lipomas, fatty masses, very soft, as were cysts. Those were significantly softer than the garden variety usual benign lesions such as fibroadenoma or fibrosis. And I was encouraged to see that because I think we were all worried that fibrosis would appear stiff, and certainly it can, but most of it does not. This is a source of false positive lesions on ultrasound for sure. And high-risk lesions were stiffer than usual benign lesions, which was interesting. So the possible phylloides tumor, atypical ductal hyperplasia, papillomas, which are a problem for us as well, and radial scars were all stiffer than usual benign things like fibroadenomas. And in fact, DCIS was stiffer yet than atypical lesions, although that wasn't significantly different, relatively small number of cases. But DCIS was softer than invasive cancers, which were the stiffest of all lesions. So you could actually predict the severity of the histopathology based on the quantitative maximum stiffness with very high reliability. So in conclusion, complicated cysts and other benign appearing masses are very common on screening ultrasound as well as diagnostic ultrasound for that matter, with a very low malignancy rate of less than 2% in BI-RADS 3 and about 10% in BI-RADS 4A. The few cancers that would be put into those categories tend to be high-grade invasive cancers, and using ShearWave elastography, at least in principle, can help us identify the few cancers which would otherwise be followed and help avoid biopsy for many low-suspicion lesions. And just to summarize, the histopathology correlated with the relative stiffness by color coding as well as quantitation. I thought this was extremely interesting, and really we don't see this kind of result in clinical experience in biology very often. Thank you very much.